Hi.
Go for it, Simon.
Hello. Sorry, got me caught a bit short there. Welcome, everybody.
I've heard it from a lot of girls. We can't hear you.
No, hang on.
Here we go.
Yeah.
We're good now.
Yeah.
You can hear me now. All right, welcome everybody.
Let's try again.
You can hear me?
Yeah.
Welcome everybody to Facebook Live. Session today is one of our journal club sessions, and we're focused on cytosine arabinoside and constant rate infusion use in dogs with meningitis, meningoencephalitis of unknown origin. And we are happy to welcome two of the authors here. We're very, very pleased that they can give some of their time to help us work through this journal article. First up, we have the first author, Kimberley Stee, and Kimberley is a board-certified veterinary neurologist who qualified from the University of Liège in Belgium in 2013 and completed a rotating internship then at that hospital. And then she worked for 4 years at the neurology department of Ghent University, where she completed her ECVN residency and worked as a member of the Epicentrum Epilepsy Clinic. Currently now, Kimberley works at Dovecote Veterinary Referrals in the heart of the Midlands, UK. And then we have Mark Lowrie, who's joined us before, and he is, again, a board-certified veterinary neurologist, European specialist, and he qualified from University of Cambridge and then worked in first opinion small animal practice. He did an internship at RVC and then moved to University of Glasgow to complete a residency. And he worked for several years then at a leading multidisciplinary veterinary centre near London before joining Dovecote. So currently Mark works with Kimberley and they put this paper together. So again, very honoured to have you here talking through your work, and happy to get going with this. The title, as we said, cytosine arabinoside, constant rate infusion without subsequent subcutaneous injections for the treatment of dogs with meningoencephalitis of unknown origin. My first question is, what was the background of your research, and what do we know leading up to this? What led you? Was it just because you couldn't be bothered giving any more injections, or was there some good old-fashioned science behind it?
Mark, do you want to answer that? Because otherwise, I mean, that's kind of part of our introduction. So otherwise, I might just crack on with our presentation. Wherefore, I'll answer your question in there probably.
Let's go ahead.
Go on, Kimberley. If you start going through a bit about it, and then we can address that. Definitely.
Right, let's do that. So I'll share my screen. Right. So can everybody see that? Hello?
That's all working. There you go.
Okay, wonderful. Well, so hi everybody. First of all, we wanted to thank Laura and Simon for giving us the opportunity to present our work here tonight. So as Simon just said, so I'm just going to talk about a recent research project that we published about a month ago. So cytosine arabinoside concentrate infusion without subsequent subcutaneous injections for the treatment of dogs with meningoencephalomyelitis of unknown origin. Let's get started. So first of all, a quick introduction. So meningoencephalomyelitis, meningoencephalitis of unknown origin, or MEO, are a group of idiopathic inflammatory central nervous system diseases that are of a presumed immune-mediated origin. So this group encompasses granulomatous meningoencephalomyelitis, necrotizing meningoencephalitis, and necrotizing leukoencephalitis. So all three of those are histopathological diagnosis. So typically MEOs are a presumptive diagnosis, and these diseases are considered to be fatal if left untreated. So what is actually the ideal treatment protocol? Well, nobody really knows. So there is not really a consensus about this. So most people agree to say that glucocorticoids are kind of the mainstay of treatment. and that adding another immunosuppressive drug to that treatment is actually improving prognosis for this patient. So one of those possible additional immunosuppressive drugs is cytosine arabinoside, which is a nucleoside analog, wherefore it actually interface with DNA synthesis, wherefore it probably kind of impairs the massive production of inflammatory cells. So a popular treatment protocol for this disease is actually the combination of cytosine arabinoside subcut injections, so every 3 weeks initially, and then, more and more far apart from each other, so up to 6 weeks for several months. And then next to that, we also give glucocorticoids that we taper down over several months again. So some studies have shown a major improvement in survival at 3 months after the diagnosis when the first cytarabine injection is actually given by a CRI rather than by 4 subcut injections 12 hours apart. So basically, we can improve survival at 3 months after diagnosis from 44% when that first administration of cytarabine is given by a subcut, 4 subcut injections, up to 90% when it's actually given by a CRI, so just the first one. So where does that come from? And that's where I'm going to answer your question, Simon. So basically, some pharmacokinetic studies have been published, wherefore it actually basically says that the half-life of cytarabine is about 60 minutes in dogs, whichever route of administration has been used. So whichever subcut or IV doesn't really matter. So obviously, if you're going to give 4 subcut injections about 12 hours apart, you can kind of picture that there's going to be quite a fluctuation in your serum concentration, wherefore your exposure to the drug is going to be quite inconsistent. So if you give the exact same dose through a CRI, well, you're going to actually get a much higher and sustained serum concentration, wherefore, this study at least kind of hypothesized that would quite improve actually penetration of the drug into the brain tissue, so through the blood-brain barrier, or wherever that drug basically needs to go to actually improve our dogs with MUOs. So obviously, seeing what this study says and seeing the big difference that we saw in Mark's previous study, I think it was quite a fair question to ask ourselves if those subsequent subcut injections, which are actually quite heavy, I think, treatment-wise for an owner, both in time and also they're not cheap. So is actually really doing something? Is actually really improving prognosis? Is that changing anything for the dogs? So I think that was quite a fair question that we kind of wanted to answer with this study. So how did we do this? So we basically did a prospective control clinical trial, and we followed up our patient for 3 years. So we consecutively recruited all patients, and we got 42 patients in our CRI only group, and then we compared those with the ones from the CRI plus subcut group of Mark's previous study from 2016. So there were 41 dogs there. So how do we diagnose MUO? Well, on previously described features. So basically more than 6 months of age for the patient at time of diagnosis. So a single or multiple diffuse intracranial abnormalities on MRI, a mononuclear pleocytosis on CSF, and absent antibodies for a recent infection on serology for Neospora and Toxoplasma. So we did exclude cases that had T1 hyperintense lesions on MRI because that's suggestive of necrotic lesion. And we also excluded dogs that were suspected to have the optic form of MUO. So this is our treatment protocol. So on the left-hand side, we have the CRI plus subcut protocol. So those dogs received at time of diagnosis a CRI of cytarabine, and then 3 weeks later, they actually received the first 4 injections, so subcut injections, so in a cycle, so every 12 hours. Then that was repeated initially every 3 weeks, and every 4 weeks, then every 5 weeks, and every 6 weeks, for a total duration of 72 weeks, which is about a year and a half, so quite a long time. So the CRI group just next to that actually received the first CRI of cytarabine at time of diagnosis, so it's exact same dose, and then just no further subcut injections. Both groups received prednisolone, so initially at a mg per kg twice a day, and then progressively tapering that down, and then stopping it eventually after 34 weeks, or about 8 months and a half. So we define success as the sustained neurological improvement following initiation and completion of the standard treatment protocol. All dogs that would experience a recurrence or the persistence of signs and that would necessitate a change in the treatment plan were termed as relapse. So our primary outcome measures were success, relapse, and death rates. So we did assess this at 4 different time points. So 34 weeks, which is when we basically stopped the prednisolone, 40 weeks, which is just 6 weeks later, 72 weeks, which is when subcut injections would end for the CRI plus subcut group, and then at 36 months, which is 3 years after diagnosis. So secondary outcome measures were time to relapse and median survival time. So we did not find any significant difference between both groups in terms of age of presentation, sex, delay to presentation, CSF analysis, as well as MRI features that have been shown to have an impact on mortality. So that includes multiple intracranial abnormalities, sulci effacement, craniocranial fossa involvement, contrast enhancement, mass effect, as well as foramen magnum and or transtentorial herniation. We did lost to follow up 2 dogs from each group. So those dogs were doing well at the time they were lost to follow up, but so we did remove them from the statistics at the respective time points that we lost them to follow up, just to not have any biases due to this. So this table resumes our primary outcome measures. So I'm not going to go over all those numbers with you because that would be very boring. But I think the important bits are, so if we have a look at the success rates at 34 weeks, so there seems to be a trend towards a better outcome in the CRI plus subcut group, even though it's not significant. So 3 out of 4 dogs are doing well in the CRI plus subcut group, whereas only 2 out of 3 are actually doing well in the CRI only group. So again, that's not significant. And then if we look just 6 weeks later, so success rate at 40 weeks, we can actually see that that trend is already completely gone. Also, so 72 weeks, which if you remember, is when we actually stopped the subcut injections in the CRI plus subcut group. Again, we can see that the success rate is pretty much the same between both groups, which I think kind of answers our question, which was, do those subcut injections after the first CRI of Cytarabine really change something? Well, I think the answer is probably no. And then if we look 3 years after diagnosis, then it's still about the same. So success rate is still pretty much similar between both groups. And also, if we look at the relapse rate at 3 years after diagnosis, we can also see that it is pretty much the same in between both groups. It was not quite a high rate, but it is, well, subcut injections or not, it is pretty much the same. Just wanted to remember you that relapse could also just mean a dog that needs a long-term, very low dose of preds, like 0.25 mg per kg every other day or every third day. So it doesn't have to be like the whole big relapse. Another point I wanted to raise on this table was the dogs that died. So first of all, we did include it in the statistics, all the dogs that died during the study period. So also the ones that actually died before the CRI of Cytarabine could be finished, or even, well, started, basically, because, well, they actually died before it happened. So we did include all of those cases because we wanted to make sure not to get any biases there. So 6 dogs died in the CRI group and 4 dogs died in the CRI plus subcut group. Important to know is that 4 of those dogs died within the first 5 days after diagnosis, which has been previously reported in the literature. And then the 2 last dogs that died in the CRI group died at 5 and 6 months after diagnosis. We're not sure what these dogs died of, but sudden death in MAO has been reported previously. So it is thought to be due to a progression of the disease in the brain, wherefore it might definitely represent an extreme form of relapse, or extremely severe form. And so all the dogs that were alive at 6 months after diagnosis were still alive 3 years after diagnosis. So I think that's kind of the main information that we would like to get, I wanted to get out of this table. about secondary outcome measures, so median time to relapse was pretty similar between both groups. So about 300 days in the CRI group and then 2 weeks earlier in the CRI+subcut group. So if you remember, we actually stopped the prednisolone at about 8 months and a half, so 34 weeks or 238 days. It's actually pretty quickly after we stopped the prednisolone. And having said that, the CRI+subcut group at that time is still on subcut injections. So I think that was quite interesting. By the end of the study, so 3 years after the diagnosis, more than 60% of the dogs are actually on a long-term small dose of prednisolone, and that is necessary to maintain them in clinical remission. I also thought that was quite interesting. So median survival time. So as more than 85% of our dogs were still alive at the end of the study, well, it wasn't really possible to measure a proper median survival time, because if you ever had to do one, you know that more than 50% of your patients need to be dead by the end of your study to actually be able to measure that. So all we can say about it is that all median survival time is more than 1,095 days. And so the reported values in the literature are between 26 and 1,025 days with various treatment protocols. So we're at least as good at that, if not a bit better. Kaplan-Meier curve. So these need to be interpreted with quite some caution. So the red line is the CRI+subcut group, the green line is the CRI group. But so for this, I actually used a complete follow-up that was available for patients, wherefore if we look at 3,000 days, that's about 8 years. So the end of the study is about here. And so obviously all the dogs that are in there were probably about young adults at this stage, but then 8 years later, obviously they're not young adults anymore. So loads of things can happen in the meantime. And so I think we followed up 15 dogs total per group until their death, which we don't know for sure if it was related to MUO or not. So the rest was lost to follow-up or doing well. So where I'm going with this is just that I think we need to be very careful in interpreting this, because all of that is not due to MUO. There are definitely some other conditions there. So the limitations of our study. So we don't have any histopathological confirmation. So the reason is that we did not request biopsy as an inclusion criteria, because we wanted our study to be quite clinically practical. And as MUO is a diagnosis of presumption, well, we did not bother to ask for a biopsy, which would increase morbidity and mortality rates. Unfortunately, we couldn't get any consent for the dogs that died in the study for necropsy, so no histopathology. Diagnosis of relapse was mainly based on clinical recurrence of signs. Repeat MRI and CSF were only performed in a minority of dogs, wherefore some of the dogs that we termed as relapse possibly might have actually having something else, so we're aware of that. Which is discussed the survival curve. So not all the dogs that died in there died because of their MUO. So careful, we need to be careful with that one. The study was not blinded nor randomized. And the treatment protocols were performed at different time points, but we did kept all variable constant as much as we could, and there was no difference in between the groups to start with. Wherefore, we're quite confident that any biases due to that would actually be quite limited. So, in conclusion, we did not find any significant difference in the medium to long-term outcome of dogs with MUO that were treated with an initial cytarabine CRI followed up or not by cytarabine subcut injections. The median time to relapse was quite similar in between both groups and actually occurred quite shortly after discontinuation of the prednisolone, so 4 to 6 weeks. More than 85% of our dogs were still alive at the end of the study period, which was 3 years, but most dogs, so more than 60%, actually needed a long-term low dose of prednisolone to maintain them in clinical remission. So I think this last conclusion kind of raises the question, could actually dogs with MUO benefit from receiving a small dose of prednisolone in the longer term? But I think that will be a subject for another study. So thank you very much for your attention tonight, and let us know if you would have any questions.
That's great. I think our hosts are hopefully coming back on. Here they are. Brilliant.
I've forgotten your love for pugs, and you reminded us on your last slide. Yeah, I mean, I absolutely like clinical study that answer a question or solve a problem, and definitely this study do both of them. It's a lot of faff to organize injection of cytarabine, whether or not it's sub-Q, having the owner coming back, doing it IV. So very useful, to have this data to actually, improve the management of this patient. There is a few questions which we'll put to you in a sec, but I just wanted to say one thing about Dovecot, where both of you come from. We talk a lot about university. They do a fantastic job doing a lot of research, training a lot of new resident and so on. But there is a few places in private practice, and Mark, your place is one of them, but train an awful lot of residents, and I don't know how many you've got at the moment, but certainly a lot, and do a lot of research. Do a lot of research and clinical research, and I think it needs to be said that there's a lot of work also happening, not only in university but in private practice, like you do. So moving on, there is a few questions. The first one by Fernando, which we know very well, is regularly following us. Some places do the cytarabine CRI every 3 weeks rather than sub-Q. What is the best option? How do you do in your practice?
I'll take that one if you want, Kimberley. Yeah, no, it's I think it's a good question. That's where we've come from with all the work we've done. I mean, we want to know what's the best way to treat these patients, and that's where we kind of evolved the work right from the beginning. I mean, it goes back to what Simon said at the beginning. Where's this all come from? But right at the beginning, we started off with subcutaneous cytarabine. It seemed to be what a lot of people were doing. And the first study we published really showed I found quite high mortality rates with dogs with MUI. And the very first study we've done, I forget the exact figures now, but a lot of those dogs were dying, and they were dying quite quickly. And one thing I've tried to do, and Kimberley's done that with this study as well, is we've very much done an intention to treat analysis. So we're looking at dogs that all those dogs that died, they may not all have received cytarabine, but there's a lot of papers out there giving outcomes on various immunosuppressive medications, saying that maybe this medication is better than that one, but a lot of them don't follow an intention to treat analysis. And as soon as you put that into it, you do find there's quite a high mortality rate in those first few days. So we moved from subcutaneous to CRI, and we showed that was better. And then here, what we've done is we as we've said, it is difficult giving subcutaneous cytarabine every 3 weeks, and it's something that a lot of people commonly do. So we've moved away from that. So to answer Fernando's question, we've moved away from giving subcutaneous cytarabine completely, and we give a constant rate infusion right at the beginning as a one-off treatment. And with the results Kimberley's shown tonight, it doesn't appear to adversely affect outcome, and in many ways the outcome's the same as if you follow them up. So that would be my response to that. That's what we do. What's the best option? Well, we're always improving, aren't we? So maybe the best option hasn't been found yet, but that's what we feel is the current best option with what we've done. But it'd be great if someone can come along and find another option again, because we're still facing mortality and relapse and ongoing problems with these dogs. So I'm sure that hopefully with time we'll find a better option still.
And 2 questions that fit very well with that. The first one from Sophie. The long-term dose of prednisolone, what exact dose? Do you go anti-inflammatory or lower?
Yeah, go on, Kimberley.
No, I was going to say basically it just depends on which dog. So most of the time, 0.25 milligram per kilo every other day or every third day is enough. But obviously that it depends on the dog. Some of them will be able to go every third day, but some of them won't. So basically when you decrease in the dog's relapsing, then you go back up, and then that's probably that dog's lowest dose that you need to keep him on. So I guess it's the anti-inflammatory at that dose, but it's quite a low anti-inflammatory.
We get down to really low doses, don't we? I mean, I think it's sometimes getting down to half a 1 milligram tablet every third day is what I try and get to. But, I wouldn't want to say it in a mg per kg dose by that stage because it's very difficult. It depends whether you're treating a growth hormone or Chihuahua. But the sort of lowest reasonable dose that's appropriate with science.
There's some great questions that fit very well. So, you start the treatment. How do you monitor them? Do you go with MRI or clinical sign? What's usually your standard of care in this patient?
Yeah, well, I mean, certainly the way that I've done it in the past is I looked at both originally to see if MRI was more helpful than clinical or vice versa. But now I've kind of moved more to the clinical response. I think, you expect these dogs to generally, most of them show a slow improvement with time. So I go on clinical signs a lot more than MRI because I've been left with a few situations where we MRI a clinically normal dog and there's still lesions there. And I've known other times when we do an MRI, it looks completely normal, but the dog is almost worse than ever. And I think it's all to do with whether you're using high field MRI, low field MRI, whether there's obvious macroscopic lesions. And it enters into this discussion of the types of MUO, more specifically, the types of GME, whether it's a multifocal one, whether it's a single local lesion, or whether it's even an ocular form. Now, we excluded some of that. We excluded the ocular form here because I think that's probably a subtype completely separate to what we're dealing with and may therefore have a different outcome. But that's why really I feel the clinical response was appropriate, and that's how we monitored these dogs in the study.
And fitting on very well with that, if they relapse, what do you do? The question is from Michael Benaim. I'll let you read the question and then you can one of you can answer.
Well, I think as far as relapse goes, what would be great and what we need, I think we all need this, is a really defined way of managing relapse in how we do it. And so what this study needs, we accept there are quite a few limitations in this study, but what we really need to do is we wanted to have a straightforward standard way to treat relapse, but we all know that's not possible. When you get these dogs in, they can be relapsing for different reasons, and they can be dogs that have side effects, and some relapses are more severe than others. So I will hold my hands up and say that some of these dogs that relapse certainly will have had a constant rate infusion of Cytarabine. We'll try it again and see how it goes. Some of them may have had a reason we couldn't do that, and we had to look for an alternative immunosuppressive. So relapses in this population were managed in very different ways, and that's why we were very specific to say that when a relapse hit, we, it kind of came out of the study, if you like. We said, well, this dog was relapsed on the treatment protocol we proposed, and that was the only way we could really make it standardized enough to give reasonable results. So what you mentioned about? Oh, go on.
What would be your? I mean, what drug you're going to go for? I think what Michael wanted to know is, do you do another Cytarabine CRI? Do you go for another drug?
Yeah, so absolutely. So I think it depends. Again, the two situations would be the relapse where the dog is really severe and it's almost a critical situation in front of you. What I do then is I'd give a constant rate infusion of Cytarabine. The other thing I'd probably do is up the pred a bit, but of course what we've done with that dog up to now is we've given it a one-off dose of Cytarabine and immunosuppressive pred and tapered it. So that hasn't worked. So I would then look at giving a long-term, a new novel immunosuppressive medication. And I think probably the one I personally reach for at the minute is cyclosporin, but that's, this is where we're going very much personal opinion and what I prefer rather than what's necessarily the right way. But yeah, I think putting that dog back on a CRI of Cytarabine and tapering pred over time is likely to lead to another relapse. So I don't do the same thing again. I try and alter it.
Okay. Just to clarification, why you didn't continue the CRI administration and how many times you inject 100 milligram per meter square?
Yeah, I mean, I think what we're doing is we're doing a one-off constant rate infusion in these dogs, and we give it over a 12-hour period at the dose that's mentioned. So
24 hours.
I beg your pardon, over 24 hours. And so it's 100 mg per meter squared injected over a 24-hour period as a one-off treatment. And the reason being, it seems to work. It's better than doing repetitive CRIs or subsequent subcutaneous injections.
And I think the other reason why, sorry, I'll just finish that one. I think the other reason why we don't repeat the CRI after the first one is that if you talk to oncologists, they're actually quite scared about the bone marrow suppression and the other adverse effect of the Cytarabine. So one-off CRI at the dose that we use it so 100 or even 200, because it's been proven to be safe and not cause any major adverse effects. So if you use like doses like 400 or 600, like oncologists do for tumors, then you actually kind of start being quite scared about those side effects and that bone marrow suppression. And if we would have to repeat that CRI every 3 weeks, then that would be quite a concern, I think. So I don't know. I hope that kind of completes the answer. But I think that's kind of why we don't really want to repeat that too often. So for a relapse, not a problem, but not like on a regular basis.
There is, at least in the UK, a lot of health and safety regulation with the handling of cytotoxic drug and the waste from the animal. Why not going for the 6 to 8 hours and going for the 24 hours injection?
Yeah, and there's a very simple reason in this study that we did that. It's because I wanted to try and make the dose and the treatment in these cases very similar to what I've historically done to allow an easy comparison. I'll be very honest and say we do now give it. That's why my confusion with what we did here, but we do now give it over a much shorter time period. I tend to aim at giving it over about 12 hours, but yeah, 6 to 8 hours would be reasonable. And so it is a problem. It's a problem handling it. And a dog on an infusion for 24 hours is very, very difficult. So actually giving it over a 6 to 8 hour period reduces the risk. And in our hands, and I'm sure in a number of other people's hands here that are listening to this, we'd agree it does also appear to be safe. So for the sake of comparison and for this study, we did what we did. But I think a 6 to 8 hour infusion is very reasonable. And actually more on top of that is, as Kimberley just alluded to, I think it's now known that 200 mg per meter squared is safe. And that's what we're now using in our clinic. But I wanted to use the 100 mg per meter squared to be honest and fair with what we'd already published.
Gotcha. Another question from Sophie. We do not tend to see side effect of cytarabine. Do you have similar experience?
Yeah, so yes, we do. Anyway, a one-off CRI of cytarabine at the dose that we use it to, so 100 or 200, well, I've never seen any report of side effects of that. And so there is also not very much about the side effects of cytarabine with subcut injection. I think there are a few dermatological side effects that have been reported with the subcut administration. But so no, we don't see any side effects with the one-off CRI or with the CRI and subcut, which we don't do anymore. But if we would have to repeat that CRI, like we just said, then yes, we would be scared for side effects. And I think there's been a study about SRMA and use of cytarabine in relapses of SRMA where they have repeated that cytarabine every few weeks, and they have actually seen quite some side effects there. So I hope that answers the question.
Very good. I don't think there's any more question, guys. Again,
I have one that I just would like to ask. It's probably more based on your experience, really, as well as reading through the paper. And you mentioned about looking at MRI at a recheck and saying it doesn't quite correlate with the clinical signs, which I think we've all found that may not just be as sensitive as we'd like it to be. And it looked like a lot of your dogs had resolution of CSF. Signs of inflammation as well at that 3-month recheck. I'd just be interested when you do your CSF reevaluations, whether it be at 1 month, 3 months, how does that help you, or does it help you change your treatment in any way? So in the dogs that had still evidence of inflammation, let's say it was in the mild region, but the dogs were doing clinically okay, do you then step up your treatment or continue to monitor?
Yeah, so we in this group, we weren't using CSF analysis at sort of 2-3 months as something we were monitoring. But we have looked at that in the past, looking at MRI at 3 months following treatment. So looking at the MRI analysis now, that looks at how CSF looks. And I think generally what we found is CSF was more useful, actually. If you're doing CSF analysis at 3 months, it was more likely these dogs would go on and relapse. What do I do now? I mean, if I do get a CSF analysis that's inflammatory at 3 months, because, we offer it to owners still to say it's the best way. I think a number of reasons that people don't do it is because of the cost, I'll be honest. Yeah. A lot of people won't do that. They won't go ahead with it. But if we are doing it at 3 months and we find an inflammatory CSF, I think I mentioned then, that's a worry. It would be a bit more of a risk, and I would have a tendency to maybe just prolong things a little bit longer. And all I'm doing is I'm tapering prednisolone a little bit slower. I'm not adding in new immunosuppressive medication,
Okay.
but only in those dogs where they're improving. Obviously, if that dog's presenting new signs, that's better with that.
Yeah. All right. Well, great stuff. Thank you to both of you for this and for the work itself, obviously, that you've discussed. As you mentioned, there's plenty of places we can go with this, looking at other drugs, looking at other doses and regimes. But this is a great amount of work, and it's a great study. And again, we've said before, we look at some of the value of these papers as to how they change our method of practice, and this certainly is going to change the method of practice. So great job.
Cool.
Thank you very much, Guy. And as I say, continue the good job. You publish so many paper, every month. It's quite remarkable. So
can I just say as well, I said a moment ago we had 3 residents. We had a 4th one start this week. If I don't say that, Sarah will hit me. So there's 4 residents. I should say that.
I know, but you're definitely doing an amazing job, at Dovecot. So, carry on the good job, and, well done, guys. Thank you very much, everyone. We hope to do another session like that next month. We'll have to find some volunteers. So if you have recently published a paper and you want to put yourself forward, please contact us. We'll be very happy, to look into that. And we wish you all a good evening. Thank you very much. Bye-bye.
Right. Bye-bye. Thank you.
Bye.